Good afternoon. This is the House Appropriations Committee. It's still Tuesday, December 16th, 2025. It is just after 2 o'clock and we are continuing going through human services departments. And now we have the Department of Disabilities, Aging and Independent Living, or DALE. And we have a few folks with us, the Commissioner Bowen, and Financial Director Bill Kelly, and Deputy Commissioner Angela Smith-Yang on the sidelines, and friends, assorted friends. So if you want to introduce yourselves and take it away, I think we have information. Yes, we do.
Good afternoon. I'm Dr. Bowen, Jill Bowen, Commissioner for DALE, Department of Disabilities, Aging and Independent Living.
Bill Kelly, DALE, Financial Director.
Angela Smith-Yang, Deputy Commissioner. Welcome all of you.
Okay. We'll open with just a mission statement, which I always am very happy to make, that the department's mission is to make Vermont the best state in the nation in which to grow old or live with a disability with dignity, respect, and independence. DALE has 5 major divisions that contribute to achieving that mission. The Division for the Blind and Visually Impaired, the Adult Services Division, which has a major focus on older Vermonters, Developmental Disabilities Services Division, including the Office of Public Guardian, the Division of Licensing and Protection, which includes Adult Protective Services and Survey and Certification, and Higher Ability, which is vocational rehabilitation focused on people with disabilities and connecting them with jobs. Our overview for BAA, our total net increase for BAA, all funds combined, is $30,313,848. That is including internal service fund increase for the Agency of Digital Services at $312,878. Our collective bargaining agreement bonus for direct care workers, all appropriations combined together, is $2,396,001. And that is broken up into attendance services program, the developmental services, the brain injury program, and choices for care. Our choices for care estimated nursing home pressures through our emergency financial relief DFR request is $14,500,000. Our choices for care system-wide long-term care home and community-based system is $2,500,000. Our choices for care nursing home Medicaid bed day pressures is $9,642,202. And our choices for care Vermont Veterans Home cost settlement to state fiscal year 24 costs is $963,267. Happy to take any questions and walk you through it.
Tom?
Thank you for this, and this is more for the committee. We talked a lot last year about the internal service fund increases for ADS. And they all represented massive increases, some of them from that seemed, and I'm not implying anything untoward, but that seemed like, oh, we're correcting what we were charging before for our services. We undercharged, or I'm just curious, just this being the first day back, do people in the committee have a memory of what the resolution of our understanding of these fund increases and how they should be shown to us? Because this is the kind of, not surprise, but this is the kind of increase in the BAA that one would have thought would have been in the budget. And I thought I'm just curious to know with committee, like, what was our understanding of how we would treat these ADS charges besides just going, oh, well, they have an invoice, so I guess we have to pay it.
So a couple of things. In this case, they put all the ADS charges in the central office. And then because they didn't know what each of the departments under human services were going to be charged. So all of that money is taken out of central office. They're reallocating the money that they already had in. So I'm not sure how much is new money. We could go back and look at that. But they were, ADS was operating with a system that was about 18 months behind. I'm sorry, Jim's not here. This was his budget. But they were about 18 months behind, and that's where we were putting money. We put in $8 or $10 million into ADS so that they could get themselves up so this wouldn't be happening again. So that was the surprise, was that everybody moved along and then suddenly they're getting a bill that was from 18 months prior. Because their systems, the way their systems work, so they were changing their system to get up to date. I don't think ADS is coming in today or tomorrow, but we'll get them in to talk more about how that's working, because we gave them all this money last year and this year. But in the meantime, if you were to go back to the central office, go back and find it, there was something like almost $3 million that they were reducing, and then it was getting spent in all the different agencies.
Or correctly
Correctly allocated.
allocated.
Yes.
And I would just echo what you're saying. It's AHS budget neutral due to that fact.
So it's not new money.
No, it's just, again, it's an unusual or perhaps just new way of representing it. So either way, it's
Yeah.
anytime there's something in a BAA, it seems to me that there's a miscalculation or a correction. And if this is a correction in one way, then that's fine.
Yeah. Yeah. So I think it's all because they decided to put all the money for ADS in the central office. And then once they knew what the numbers were, they were going to reallocate it out. Okay.
Like I mentioned earlier, it looks to me by looking at the BAA that most all the agencies have corrected that. This must be a special case.
Well, I think in this case, it was just easier for the central office to take the hit. And then it's just, so it's an accounting thing. It's just moving the numbers within the same agency. So I'm less worried about it if that's all it is. Tip?
Yeah, I understand the, Medicaid bed pressures. But can you explain the nursing home pressures at 14.5? I think it was much higher last year.
Yep.
And yet still 14.5 is a lot. So I'm just wondering, what is that money being spent on?
Okay, so, again, you're correct that it was 21 million last year and it is 14.5 million. What we said in last year's BAA, that our expectation is that some of the interventions that we were making, such as the 2-year nursing home rebate, the 2-year nursing rebate, was going to have more of an impact for this go around than it was for last go around, because each 2-year nursing rebate is based on 2 years prior. And so therefore, when the 23 was done, it was based on 21, and it really didn't reflect what was happening in those days. And so the difference was much bigger. And with the new rebase, it closed the gap to some extent. And so we expected there to be some decrease of EFR need. Just to remind everybody that it's an emergency relief fund. It's not a pre-budgeted amount. It is intended to relieve financial pressures of nursing homes that are at risk for financial failure. We are in a very difficult time for nursing homes. We have been, we continue to be. They are filling up quickly. The need is clearly there for the whole system, the whole long-term care system. Nursing homes in particular, because we're talking about EFR, we're continuing to age. That's not a surprise to anybody for this state. At the same time, managing and succeeding financially with the pressures that are primarily, but not solely, but primarily driven by the workforce challenges, where they are still requiring, still needing to, especially with the LNAs, which is the, the backbone of the nursing home workforce, to contract out. And it remains an extremely expensive proposition. It is still difficult to hire. We have put some programs in place around recruitment, including the use of funding that was provided by the legislature, to provide for support around recruitment for LNAs, and that is proceeding at the nursing home level. And we ran a campaign called Careers in Caring. I hope you saw it. To work on recruitment. So those are helping to reduce the need, but it is still pretty profound.
It's just, there's a striking difference in the way I think we as a state, I don't see the nursing homes as distinct from designated agencies. In the sense that, I mean, we will build in COLAs for nursing homes. We will have an emergency fund. The designated agencies are actually an arm of the state. And I just am, I'm sorry. I'm just making a statement about the inconsistency kind of across the system of care with which we treat certain types of care and not others. So
can I respond to that? Because it wasn't actually a question.
no, it was a statement, and I apologize.
I do want to respond to that. So there is actually a stabilization fund that is available through DIVA for other providers in other areas in nursing homes. So I'll just put that aside. The nursing home system is teetering, and the investment that is needed to ensure that we can't lose like a single bed. I mean, we're at 88% capacity in the system with a growing demographic. And I think people understand that we are a growing demographic, but I don't think they truly appreciate what that means. We have an average age in our nursing homes of somewhere around 84 years of age. And people are living longer. There's complex care that is needed. People have multiple challenges, and we have to be prepared for that. In many ways, Vermont hasn't really invested in the infrastructure of the nursing home system for a while. Several years ago, there was an investment in the community-based side, which still needs to be. It's not an either or, it's a both. The home and community-based services programs for older Vermonters, the ability to stay at home and to have choice and to have residential care. The whole continuum needs to be strengthened, but so does the nursing home level of care. And during the pandemic, you saw, obviously, nursing homes drop. Money was taken out of that system. We are back to those levels and continuing to rise. The pre-pandemic levels, you could see that the occupancy drop came back up. So what nursing home operators are seeing now are greater costs for staffing, inflationary costs. They're seeing the staffing challenges continue, and much more complex cases, people coming in with many more complex issues. And so it's a hard business to be in. When a nursing home closes, and several of them are at risk for closing, but when a nursing home closes, it is very hard to find a buyer. It's not like we have choices. Oh, this is better, this is someone that we would love to have come run the nursing home. We're lucky if we get one viable buyer. So I just want us to understand that the emergency relief fund is not, it's essential for right now. And everything that we do to try to lower it, the fact that we were able to get it down from last year is fabulous. And it does show that there's some, some movement going, but it's not the long-term answer. And it's absolutely necessary. You could not maintain the nursing homes without it.
I have John and then Lynn.
Thanks for coming in today.
Sure.
Good to see you again. So, with what you just described there and knowing that we're doing our best to provide some sustainability here. Nursing homes we do have, we can't afford to have any one of them really close. We're at capacity here. So we have to kind of look and see what's in front of us here today here and in the coming financial budget year here. But where do we need to move? What do we need to get to here at a point in time? So we're not just at capacity all the time. We have some margin there.
Yeah, we're working on stabilization plans.
Right.
It's in the planning phase. We need to be thinking 5 and 10 years out about where we are going to be able to go. We're looking at workforce, obviously, but not just workforce. We're looking at financial stability. We're looking very closely at quality. We're looking at complex care because, as I said, we are seeing so much more in the way of complex care. We want our nursing homes to be able to receive and serve people with complex care. And not all the nursing homes today are able to do that. We did build or open Mission Care, which is intended for that purpose and fulfilling that purpose. There are other nursing homes that do, and we do have enhanced rates for those particular challenges. But we need that to grow over the years. I mean, we are looking forward at what might be needed as the years go by. But this is just to say that we are forward thinking. We're trying to imagine 10 years from now. So that's what we're working on, is planning so that we can get to 10 years from now. The EFR is just necessary in order for us not to. Let me just say also, when somebody asks for an EFR, it doesn't mean they get an EFR. There has been one so far this year that has been approved. There's another that has been denied. And I believe there are three more pending review. It's a deep dive. It's not just, hey, I'd like more money. It's, are you actually teetering? It's a forensic audit. It's a deep dive audit. And if it's determined it's necessary, it's at that level.
Lynn, did you have a question?
Yeah, I'm just going to, I've got a couple of simple questions and one big question. One of the things that I see with nursing homes and all that home care, the elderly care that you're listing here under choices for care, is that a part of the fragility of the system financially? Is that a product of the payer mix? I mean, it seems like nursing homes, many of them primarily depend upon Medicaid.
Mm-hmm.
There's no Medicare. It's a small piece of private pay.
Well, so the Medicare is if they are serving short-term, like rehabs, and most of them do have some beds for that. But yes, to your point, yes, it's Medicaid dollars.
Yeah, percentage, do you know?
Oh my goodness, do you know the percentage?
The federal share?
Well,
The
yeah,
Medicaid
for whatever,
percentage.
Medicaid paid the total.
80% of that.
80%.
Yeah, of the nursing
Versus
home
commercial.
operation, I'm not sure.
But it's a,
But if you're in that level
it's a
of,
burden, that's part of the burden, because they don't get paid enough to cover their costs, probably.
well, and we do encourage folks to bring in some of the complex care folks, some of whom, are waiting to be able to get access, and there are enhanced rates associated with them. So if they have the ability to serve that level of care. So one of the things we're looking at is what needs to be done to be able to help. And so some of that we are hoping can come through some federal funding, if it comes through, to be helpful in some of the areas. The nursing homes themselves are particularly expressing interest in vents and dialysis, for example. And if we are able to get some federal dollars associated with that, might be able to serve more of the folks than they can currently serve. Behavioral health focus continues to be a challenge, but some are doing that work, and when they do that work, they are getting enhanced rates. Agree to your overall point.
Because one of the things that I understand, and I don't know if it's changed, but this bleeds into the hospitals, where the hospitals have patients who are really nursing home bed ready. They can't get placement, and so they're sitting there collecting a very reduced rate for people who are taking up hospital beds.
So we track that very, very closely. That was one of the impetuses behind Mission Care, and that actually, you could actually hear a sigh of relief at the hospitals when they were beds that were created there to help pick them up. But we watch that very closely. I know you get a report every week, and we watch closely the what is happening at the hospitals. It is less than it used to be in terms of the boarding, but it does go up and down. But
So
it
you
is an
watch
issue.
that, and then they're working on something. Now, the last thing I have is Choices for Care is listed in all of these. Choices for Care was the home care, or does that now just apply to all of these senior options?
Choices for Care is the continuum. Do you want to be specific?
Used to be for people who stayed at home and took care of a
That's
person.
home and community-based services, which is a part of Choices for Care, but the funding.
Choices for Care is everywhere care.
Okay.
Yes, so that's why we really don't, from a budgetary perspective, really think about it. I mean, it is a system.
Okay, thank you.
So I have Tom and then Dave.
Thank you for bringing up the demographics, and you talk about 5 years or 10 years down the line. In 5 years, all of the baby boomers are going to be 65 or 66 years old. So we know exactly how many people there are going to be, we're going to see that bubble just keep going until it's no more, which will be 30 years, roughly, considering we're all living that much longer. So one of the things that I've been frustrated with, and it's never been part of my committees or anything like that, is this lack of planning for we know at birth to 6, how many kids there are and how that's going to affect the schools moving forward. And I'm just curious to know, how do we build a program, not just 5 or 10 years down the line, but for 30, we haven't contemplated the effects of having that many people going into retirement age, except in pieces, pensions, state pensions, whatnot, in this case, nursing homes. And I'm just,
Please finish.
so many people, and we keep hearing about how there's not enough people to work. And how much of that is tied into the fact that there's just not a lot of people compared to what it was with the baby boom. And if you need this many people, if there's a certain percentage of that's going to be in nursing homes based on past performance of care for the elderly, what are we going to be able to say more than 5 or 10 years down the line? Because in 30 years, we'll all be gone, presumably. And then we'll have this other system. But in the meantime, this crisis of the instant is what we're paying attention to, which is the most important piece. And I'm just curious, not so much have other states done this, but are other states contemplating this incredible need financially from the government at a time when it's not there?
So Vermont is one of the few states that has deeply contemplated this and created Age Strong Vermont. And if you haven't, I would recommend to look at that. We're in year 2 of a 10-year, really incredible plan. I read it before I came here, and it was one of the drivers for me. Because it's a multi-sector, input, multi-year plan, and there's only a few of them in the country. I can tell you that I came from Philadelphia, which was Pennsylvania, a year and a half ago, and they also have an aging population without much of a plan. There isn't really great planning out there for this. I think that to some degree, people know it, but don't truly appreciate it. In Vermont, your percentages are so strong because you don't just have an older population. And by older, I mean fabulously older, okay? Because those who are 60 and above in the state are doing amazing things for the state. I just like to make sure we highlight that, right? They're the
Aged
backbone
is
of our.
still defined as 65 and older, though.
Yeah.
That's a problem.
Well, that's an excellent point. I mean, they're an active part of our workforce. They are the backbone of our volunteer force. They are contributing to the economy and all that. So just to do the positive spin for a moment, but we have so many fewer younger folks that the percentage. So this, one way to increase the percentage is to decrease, and the other way is to, right? So I know that that's an important part of a lot of the priorities the governor has is focus. And that's great. So that's contemplated in that way. But as far as is there thoughtful planning, we're wrapping up year 2 of the 10-year plan on Age Strong, and we will be putting out a report on where we are, what we have put into place, because it's the entire continuum that needs to be addressed, right? It's the preventive pieces of it, the early intervention pieces. So the upstream, all of it will contribute to what this state will be able to provide, and what it will be, what the experience of living in Vermont will be over the next 5 to 10 years. So we'll make sure that everybody gets a copy of the year 2 report as we go on with year 3 and 4. Like, there will be a lot of activity going on through that umbrella. And there's a lot of shared partners and stakeholders and community involvement in that work. The nursing home piece of it, this is why the EFR always pops up, because it's costly. Because nursing home care is incredibly costly. And we do want to be able to figure out how we can make sure that that part of the continuum is available, that it has high quality, and that the issues around workforce for the nursing homes, capacity, quality. I have a circle here. It's financial stability, quality, complex care capacity, and workforce, and that's our planning. So that's what's being contemplated. Some of it's being worked on already, and some of it is in the next piece of the turning and planning. We're not going to go away with this. We're not going anywhere. We are working on this. We'll need help, but of course.
Thank you, Dave.
I hope 3 quick ones. I'm conversant with the impact in the future on hospital provider taxes. Can you speak to the impact, if we know it, on the impact of nursing home provider taxes in the future? Are they scheduled to be reduced the same as hospitals?
Not that I'm aware of.
Okay, thank you.
I don't think so, Dave.
And Nolan would tell us probably. And then enhanced residential care, there's a fair amount of consternation in the industry because, as you know, the tier 1 reimbursement was reduced, and tier 2 and 3, I believe, was increased for ERC payments. Can you speak to the known impact of that and the rationale?
Yeah. Okay. So what happened there is that the increase, or the market study, the rate study that was done, which was done a couple of years before, looked at all of the tiers together. The ACCS, which is the first sort of entry piece of it, And then a tier 1, tier 2, tier 3. But the ACS piece of it was put in as a rate study that was meant to go sort of all at once. And in combination, it showed a significant increase for the providers. What happened was only half of it was approved. So initially, only half of it was approved. That was the ACCS piece, and that was approved first. And that was done by the legislature. That was approved first because that's the piece of it that impacted everybody. So everybody got the ACCS. So it was a big increase, huge increase for everybody. When the second group went in, people looked at that as a whole, right? The ERC rates are up. Everybody was great, they're up. And it got passed as a whole. In other words, it went in as a whole, ERC rates, not one here, right? Like ACCS went in. If you put the whole thing together, what passed was great for everybody. However, because it was separated out, that goodness that came with the ACCS was like old news already. And then the increases for 2 and 3, which were great, which looked like they balanced off the ERC1, it didn't feel that way to those who were only providing ERC1, even though everybody made out as a whole. If you put a circle around the entire thing, everybody made out because of the ACCS. But for those who were only serving tier 1s, it wasn't a happy day.
And tier 1 of the lighter care.
Yes, tier 2 and 3 got some pretty good upswings. So as a whole, the system did well with that. But there's a lane where they found it difficult. There has been efforts to make sure that everybody was getting the correct level. So in other words, if they were at level 1s, but they actually met criteria for level 2 or 3, they were able to adjust that. There were only a few providers who, out of the whole pool of providers who were impacted, because several of them had met several tiers that they were serving. Those who only had tier 1 had a harder time. And some actually applied for that stabilization grant that Diva is managing.
Our policy committee is going to discuss this, and we'll see if it comes back to us. My final question is, we inadvertently omitted case managers from the inflationary increase we granted the choices for care providers last session. If somebody could tell us, if we were so inclined to want to include them with that inflationary increase the way we had in the past, what would that cost? I don't expect you to tell us today, but I think it was 179. But anyways, we should at least be aware that those folks didn't get that increase. And in order to make the whole choices work, case management's important for obvious reasons.
So I could say a few things. I don't think it was accidentally omitted, but if we wanted to increase, I can certainly give you the amount. I think it's a different number than
I
one.
think it was maybe accidentally omitted by us, not you.
Yeah.
But anyways, yeah.
I think that they would direct care that, right? There was something different about that.
It's because there was already an increase related to case management in the ups and downs.
Okay.
But the history of it doesn't matter. I can get you the amount of a 2%.
Thank you.
Yeah.
Thank you.
More you want to share with us?
Do we have more?
Yeah.
No, but I do appreciate, the specific questions that you're asking we do appreciate them. They are so relevant to what we're working on. I'm not surprised that you have all those specifics, but from everybody.
No,
We just get a quick clarification on the veterans home cost settlement for fiscal year 24, please. The 963, that's another recurring thing that they come back and ask for more. And I know that their Medicaid reimbursements are also like 2 years behind or 18 months behind. Is that part of what's playing here?
Well, okay, so as an estimate in the base was nearly $4 million. Right, and so the cost settlement total was 963,267, more than that.
So yeah, this is a cost settlement for the 24 costs. And as you remember, last year was the first time that we had actually put an estimated amount in the base budget for this purpose, because it would occur every year. And that estimate was, approximately 3.9 million. The actuals came in at almost 4.9. So that's the differential.
So the idea is to get better at estimating, but it was the first year that you estimated because we've been using budget adjustment to balance this in the previous years. And this is the first year of really trying to make that change.
Wasn't a bad.
No, because it's been 5 million or 6 million in other years in budget adjustment. So this is, it's not perfect, but it's a big improvement for what it had been.
Yeah, and for Nolan, and I could answer what a 1% increase would be for the case management. 70,452 gross GC. That's 1%. So whatever percent you want to add, the math is simple.
Wayne has questions.
So this is just spending authority, right? The 963,000.
Correct.
Money came in from the federal government. More money than what we were anticipating. So this is just spending authority to allow them to be able to spend that money.
Any other questions, folks? Thank you very much for coming in.
Thank you.
Appreciate it. I keep saying this after I say thank you, then I remember I want to ask just, things going all right, working on the budget presentation for us. It's going to be a little different this year, for not just the ups and downs. So hopefully you've seen all that and ready.
We're looking forward to. We're looking forward to it.
We're looking forward to it. Great, thank you so much.
Thank you.
Okay, committee. We're just about on time. We're going to take a break and then we're going to hear Department of Health and DEVA, where we have